Greetings, and thank you for joining us for today's webinar. My name is Joe Macbeth, and I am the Executive Director for the National Alliance for Direct Support Professionals. And joining me today for a follow-up to March 11th webinar on the coronavirus for direct support professionals, the role of the direct support professionals, is Dr. Rick Rader. Dr. Rader is the Vice President of Public Policy and Advocacy for our partners at the American Academy of Developmental Medicine and Dentistry, the AADMD. And we have a very good, strong relationship with the AADMD, and we thank them for this partnership. The last few weeks have been unsettling, to say the least, and we're happy to be able to provide the direct support workforce with some really crucial information, and this information is specific to the direct support workforce, and we're following what's happening out there, and we know there's a lot of anxiety and there's a lot of stress and concern about keeping the people that we support healthy and safe through this pandemic. One of the other things that we're really happy to announce is a live town hall with Dr. Rader and the NADSP team. I'll be joined with John Raphael, Dan Hermrich, Desiree Laux-Bear, and Nicole Ndama. We're going to be able to do this live and entertain your questions and begin a dialogue with direct support professionals and share with Dr. Rader and the NADSP team some of your concerns and ask some questions and provide some feedback with you. So please save that date, April 3rd, 1 p.m. Eastern Time, 10 a.m. Pacific Time. We're going to be recording that webinar, and we're also going to be recording this webinar because we know many direct support professionals are unavailable to hear it today. It will be placed on our YouTube page, and on the YouTube page, you will also see for our deaf community a closed captioning. And if you need a transcript, give us a couple days, email us at communications@nadsp.org, and we will be happy to send you a full word-for-word transcript of today's webinar. So with that, I again welcome you, and I'm going to turn it over to my friend and colleague, Dr. Rader. Doctor, thanks for joining us today.
Thank you, Joe, and thanks to the NADSP for putting this together. 2 weeks ago, the National Alliance for Direct Support Professionals invited me to provide a webinar on the role of the DSP in the era of coronavirus. From its widespread viewership of over 20,000 individuals, it was obvious that it was a subject that had incredible interest, appeal, and certainly necessity. We provided hands-on, practical, and realistic information for the DSPs to provide the best safety and health-relegated guidelines. At that time, we stated that the information, facts, statistics, and recommendations were indeed a moving target. New findings were coming in fast and furious, and the landscape was changing day by day. That has not changed, and the need for an updated DSP webinar was evident. This webinar is and was not intended to replace the original one, but to serve as a companion, a tool that would present the latest information as it has become available. Like the first 1-2 weeks ago, this webinar will require further updates in the future until we can better understand, control, and outwit the virus. Let me begin by saying that any update should include the most recent updated statistics. As of this morning, there have been 68,594 cases of coronavirus in the US with 1,036 deaths. Worldwide, there have been 488,055 cases with 22,032 deaths. The problem with raw statistics is that they are like reporting the final scores of a football or basketball game. Yes, there was a winner and a loser, but the scores don't provide the details that can often reveal insights, rationales, current strategies, and certainly don't reveal where the teams are in the standings for the entire season. And like it or not, we are indeed in a season, a viral season. And thus these raw numbers can be misinterpreted, leading to unnecessary fear, anxiety, and confusion. The statistics need to be understood in the context of where we have been and where we are going. We'll talk about that later in our discussion. Knowledge is power. It's a popular phrase actually coined by Sir Francis Bacon in 1597. Knowledge provides us with the power to help others in a variety of ways. It is also something that is good for our own self-esteem. In addition, knowledge imbues us with authority and enables us to act and interact with others in an ethical and moral way. Knowledge can include skills, experience, and education. At best, it includes all three. Of course, knowledge by itself is an empty toolbox. It needs to be converted to action, and that action needs to be measured and evaluated. So how have DSPs fared in the short time they were called to face the challenges imposed by coronavirus? While at this time the observations, outcomes, and stories are purely anecdotal, the consensus from administrators, families, surveys, state health department officials, individuals receiving support, and the legions of DSPs themselves is that, as expected, they did us proud and performed as the professionals they claim to be. And despite the fact that you have been put in some very stressful situations, you, have risen to great heights. We want to continue to provide you with the tools to enable you to press on, but congratulations for the display of integrity, commitment, and dedication that you have portrayed to the community so far. Be beautiful if you can, wise if you want to, but be respected. That is essential. As a DSP, I know you have been called lots of things, probably some things you didn't deserve or want to hear. But one thing I can assure you that you are and need to hear is that you are essential. From the time you show up for work until the time you close the door behind you, you are essential. Essential because that is the role you play and the things you provide. Why being essential is particularly important these days is that in certain states, the government has declared that only essential workers go to work. Non-essential workers have been instructed to stay home and not go to work. The United States Office of Personnel Management defines essential or accepted employees as, quote, those who are performing emergency work involving the safety of human life or the protection of property or performing certain other types of accepted work. If ever there was a job, a role, a profession, and a person who qualifies as being, quote, essential, it's the DSP. You check all the boxes. The NADSP is working diligently to have DSPs designated and recognized as being essential. If you live in a state where DSPs are not considered essential, please contact your agency's CEO and have them issue a letter defining your role, responsibilities, and obligations to the individuals you support. Hopefully you will not need this, but I would feel more secure if I knew you had it in your back pocket. It could have future legal and financial implications. So where we are, or maybe where are we, is a better introduction. Let's take a look at some of the best practices that DSPs can initiate starting tomorrow. Before we get into these, let me state that none of these protocols are groundbreaking, heroic, or intended to have you win the Nobel Prize in medicine. They are evidence-based methods to prevent or break the spread of disease, and that itself is monumental. You won't find yourself on the 6 o'clock news with a video of you disinfecting the dining room table with the announcement, despite having 1,000 things to do, we have footage of a DSP actually wiping the bathroom sink. Stay tuned. Sometimes the best things, the smart things, are mundane, intuitive, but often overlooked. Viruses can live for a time on surfaces outside the human body. It may be possible to contract the coronavirus by touching a surface or object with the virus on it and then touching your face. It is believed to spread mostly from person to person through respiratory droplets produced when an infected person coughs or sneezes. The virus can be detected in aerosols for up to 3 hours and on plastic and stainless steel surfaces for up to 3 days. It is imperative to clean and disinfect surfaces that invite human contact. 2 points of interest to DSPs are 2 definitions. Firstly, cleaning. That refers to the removal of germs, dirt, and impurities from surfaces. Cleaning does not kill germs, but by removing them, it lowers their numbers and the risk of spreading infection. Disinfecting refers to using chemicals to kill germs on surfaces. This process does not necessarily clean dirty surfaces or remove germs, but by killing germs on a surface after cleaning it. It can further lower the risk of spreading infections. Surfaces that require ongoing cleaning and disinfecting include tables, doorknobs, light switches, handles, desks, toilets, faucets, and sinks. Be sure to wear disposable gloves when cleaning and disinfecting surfaces. Clean hands immediately after gloves are removed. Use solutions that carry EPA-approved emerging viral pathogen claims. When doing laundry, do not shake dirty laundry. Wear gloves. If possible, launder the items using the warmest appropriate warm water temperatures. Dirty laundry from an ill person can be washed with other people's items. Clean and disinfect clothes, hampers according to guidance for surfaces. Try to use a disposable bag inside the hamper lining. Refer to the EPA. Go to their list N as in Nancy, which is a list of disinfectants for use against COX-V2. These list the approved effective cleaning and disinfectants that should be used in group homes. Go to EPA.gov. The bathroom should be considered ground zero for hosting both bacterial and viral colonies. Be diligent in your cleaning and use of the bathroom. Take care and make sure you're not making these icky mistakes. You don't shut the toilet lid when you flush. If you leave the lid up when you flush, germy water particles can spray across the room up to 6 feet away from the toilet. So be sure to use the lid down flushing protocol. You store the toothbrush in the medicine cabinet. Trapped in a cabinet or container, your brush may not be able to dry between uses, creating a welcome environment for bacteria. Toothbrush holders can host and hold the highest amount of bacterial and viruses, germs, and mold in the bathroom. The American Dental Association recommends storing toothbrushes in an upright position and not touching other brushes to mitigate the risk of cross-contamination. You leave your makeup and brushes out on the counter. Anything you apply to your face should be kept out of the path of toilet germs. If you store your makeup in the bathroom, the room's moisture can make it even more susceptible to bacterial growth. You use your loofah for way too long. Toss them every 3 or 4 weeks and do not share them, because the first thing you wash will have remnants from the last thing they washed. You let your towels dry on hooks. Launder the bath towels after every 3 uses, but only if you hang them spread out to dry on a towel bar. If you hang them on hooks, moisture and any excess soap that's collected can stay trapped between the folds, which could lead to mildew and bacterial growth. You never run the fan. Bathroom moisture can cause a host of yucky issues. Okay, so yucky may not be a medical term, but I'm sure you get the idea. So run the fan when you shower and for 15 to 20 minutes afterward. You never clean the shower curtain. You can often toss shower curtains in the washing machine. Check the washing instructions. Also, pull the curtain across the tub, not scrunched to one side between showers, so it can air dry thoroughly. And here's a good cardinal rule. You use your cell phone in the bathroom. Anything you take into the bathroom can get contaminated with lingering germs or fecal matter. 16% of cell phones have it. And even if you wash your hands after every bathroom break and you don't disinfect your phone, then you have to put it to your face to take the next call. Don't get me started on how wrong that is. One of the most often asked questions is, can wearing a face mask reduce your risk of coronavirus? And the short answer is yes. The long answer from the Johns Hopkins Center for Health Security is, face masks can help protect against many respiratory infections that are spread through the droplet route, and that includes coronavirus and the flu. Wearing a mask can prevent those droplets from hitting your face or mouth before they drop to the ground. They can also prevent you from touching your face, especially your eyes, nose, and mouth. Wearing a face mask can be uncomfortable and exhausting to use over time. They're not designed to be worn 8 hours a day. If the mask does not fit properly, its effectiveness will be reduced. The CDC doesn't currently recommend that the general public wear face masks to prevent viral infections. They say that people who have been diagnosed with COVID-19 or are being evaluated for infection should wear a mask when they're in the same room as other people. The best mask is, of course, the N95 respirator, named after the 95% of the pathogens that are blocked by wearing it. It is currently the most effective type and is used by health providers. They should not be used for extended periods of time. Users have to be trained on how to properly fit them. Because of the shortages of masks, the current recommendations suggest allowing the reuse of masks, but only as a stopgap mechanism because of the current shortage. Many people are spraying the outside of the mask with a disinfectant. Certainly not optimal, but this is a crisis. Experts say that the painter's masks are worthless when it comes to respiratory protection. Surgical masks are designed to keep what's in a surgeon's mouth and nose from getting into a surgical field. They are not airtight around the edges. The evidence that these low-level masks protect against infection is meager. There is also the danger that they give the user a false sense of security and protection and that therefore they might ignore the mainstay of protection, and that has always been proper and frequent hand washing. Also, if you adhere to social distances, there is no need to wear masks out in public. If you are using a cloth mask, be sure to wash them thoroughly at the highest temperature and allow them to dry completely. Wash after every shift. You should not feel protected with homemade t-shirt masks. If you feel more confident with using a mask of any type, go ahead and continue to use them, but realize that they might simply just be a placebo. The use of goggles is recommended as opposed to safety glasses. Ensure that they are fitted close to the face and not allow the eyes to become contaminated. Because the viral particles eventually succumb to gravity, they eventually fall to the ground. So the floors are collecting points for the still virulent pathogens. It's not rocket science to appreciate that our shoes become effective modes of viral colonies. It is suggested that you don't walk with bare feet or have the individuals walk around in their bare feet. When DSPs return to their homes, they should remove their shoes and disinfect them, or at least leave them outside. DSPs should also remove their clothes after work and throw them in the laundry. They should also take a shower. It is also recommended that you thoroughly wash your hair, including your eyebrows and any facial hair. Hair has been implicated as a favorite storing house for viral colonies. These will provide another modicum of protecting your own families from any potential viral assaults. Let's look at some of the methods to prevent the spread of coronavirus in group homes for people with IDDB. Adhere to the policies and procedures relating to visitors to the group homes. This includes neighbors, friends, workmates, families, and surveyors. The regulations were put in place based on the best healthcare policies, and you have an obligation to carry them out. Ensure that there is an adequate supply of prescription medications being properly stored, especially refrigerated if necessary. Ensure that you have access to pertinent medical records. Be sure you have the contact numbers for family members, healthcare providers, conservators, day program supervisors. Encourage ongoing personal hygiene practices. To the extent possible, this should be carried out by the individuals themselves. Since we're all hibernating, watch for subtle signs of anxiety, depression, pain, anger, or confusion based on extended hibernation and disruption of normal activities. Maintain active support and engagement. Provide positive activities, including physical activities, such as individual and group exercises, balance programs, meal preparation, redecorating, group games. The Special Olympics have exercise videos online that I recommend highly. Have access to appropriate protective garments and the ability to properly dispose of them or replace them. Certainly be ready to explain to the extent possible what exactly is going on, and to reassure the individuals that you support that you are there to help them and won't leave. Be prepared for extended self-quarantine of all the housemates if warranted, and continue to provide supportive decision-making whenever that opportunity is presented. How many zeros are there in a trillion? The Senate passed a massive economic stimulus package that will keep the nation from falling into a deep recession because of the coronavirus crisis. This will inject approximately $2 trillion into the economy. We are confident that this will be signed into law by the end of today. Why is this important to DSPs? It will provide 4 months expanded unemployment benefits, supplemental payments to families, relief from possible evictions, loans to small businesses. It will provide a one-time check of $1,200 to Americans who make up to $75,000 a year. This package will help DSPs during this crisis and hopefully provide the security of keeping their jobs and supporting them and their families until things return to normal, our old normal, that is. Emergency situations and natural disasters such as hurricanes, pandemics, or mass casualties can quickly overwhelm healthcare systems. The last thing on people's minds in those situations is complying with the HIPAA privacy rule. Sometimes, but not always, the U.S. Department of Health and Human Services steps in and issues a waiver of some HIPAA requirements. For example, during Hurricane Florence, which ravaged the Carolina coast and produced devastating flooding, Health and Human Services Secretary Alex Azar waived sanctions and penalties under certain HIPAA privacy rules, provisions in the areas affected by the emergency. The need to share patient medical information to assist in their medical care is considered allowable. DSPs are encouraged to check with their agency to ascertain what they can or can't disclose, even during a declared emergency. Personally, and only my opinion, that I would rather provide potentially life-saving information to medical teams and face whatever consequences there are than to withhold that information, which might compromise their health and well-being, or worse. In a crunch and without any guidance, the DSP will be required to make their own decision. Decision-making by the seat of your pants is not something new to DSPs. If it enters into the legal abyss, I will personally testify in your defense. So where is this thing taking us? Firstly, you have to realize that predictions, projections, and presumptions are a little more than guesswork. No one has a crystal ball, and previous predictions are comparable to weather forecasts. Both use science, mathematics, formulas, patterns, algorithms, history, and then pepper it with self-opinion. So you can't take this to the bank. In the past, medical predictions declared that Pasteur's gum theory, germ theory, is ridiculous fiction. In 1954, the National Cancer Institute declared that smoking is a minor health problem. And in 1969, the then Surgeon General of the United States said that within a year, we will have a cure for every known infectious disease. And what about the prediction that X-rays will prove to be a hoax? So medical and more specific disease predictions can be a crapshoot, but somehow we are mesmerized with hearing where is this thing taking us. Dr. Anthony Fauci, director of the National Institutes of Allergy and Infectious Diseases, said, quote, "Bottom line, it's going to get worse." The American Hospital Association put the potential death toll at hundreds of thousands if efforts to mitigate the epidemic fail. Dr. Tom Frieden, former director of the CDC, said, "The worst case scenario, but one that is not implausible, half the US population would become infected and more than 1 million people would die." Experts say that anyone who says that they know where this is going with confidence doesn't know enough about it. The case fatality record for COVID-19, higher than 3% so far globally, according to the WHO, is an evolving number that depends on multiple factors, including access to robust healthcare. The actual lethality of the virus is hard to determine because many people have mild or no symptoms and are never formally diagnosed as having the virus. Some COVID-19 deaths may also have been missed, possibly mistaken as flu-related. In his Capitol Hill testimony, Fauci said that a plausible COVID-19 fatality rate could be 1%. That, he said, is 10 times as lethal as seasonal influenza. He was clear this is more dangerous than the flu. That has yet to be proven. In my own opinion, the problem with forecasting is you have to know where you are before you know where you're going. And because of the problems with testing, we're only starting to know where we are. At the end of the day, regardless of the predictions, which are either doom-based or optimistic, that it will shortly self-extinguish, we all still have a responsibility to adhere to the best practices of individual and group protection. So let's keep that at the forefront of any predictions. And in the tradition of deciding if the glass is half filled or half empty, I present this image of empty beds and ask you to decide, are the beds empty waiting for an avalanche of patients, or are they empty because the threat has been managed and the patients have been discharged? One thing is for sure, the cavalry needs help. The workforce crisis in the era of coronavirus is more significant than ever before. It is well known that there is a critical shortage of DSPs. This has been made even more noteworthy in the age of COVID-19. Let's look at how this will impact on DSPs and, of course, the individuals who rely on them. Because of stated mandated shutdowns of non-essential businesses and staff, there are an anticipated 7 to 8 million layoffs in the restaurant industry alone. Many of them could be potential candidates for becoming DSPs. Of course, we want DSPs who want to be DSPs, not because of the cry of, "I need a job and quick." But sometimes being exposed to something you never thought about can be the seeds to success. Because of the need for quick turnarounds and fast tracking, many states and agencies are enacting exemptions from what was previously mandatory training before being assigned to individuals. These exemptions may include delays in training in CPR, first aid, defensive driving, crisis intervention, and other vital training that would be delayed or relegated to online instruction. Therefore, current DSPs have an additional responsibility to oversee this new wave of undertrained hires. The current climate with this virus may also impact on employment laws relating to personal time off, sick days, need for quarantines, extended shifts, staff-to-client ratios, etc. The DSP is encouraged to check with the Human Resources Department to see if any changes in current employment policies will impact on their status. In terms of DSPs returning to work after having symptoms suggesting coronavirus, here are my guidelines for reinstatement. DSP should be allowed to return to work after they are fever-free for 72 hours without the use of fever-lowering medications. Medications used for lowering fevers include acetaminophen or Tylenol, ibuprofen, Advil and Motrin, naproxen sodium, Aleve, or aspirin. One thing for sure, we're not simply rolling over. Here are some clinical and treatment updates. The U.S. was asleep at the wheel when it came to having diagnostic tests available in all sectors. To make up for that, the government has been working with more than 100 diagnostic test developers. In reality, we don't really know how many test kits are now available, as this number fluctuates daily, as more and more test developers get their tests in the field and start testing patients. It's important that we get up to snuff in testing, not only for individual patients and their immediate contacts, but for public health planning and management. There are currently many efforts worldwide to quickly and safely develop a vaccine for COVID-19. However, experts say a vaccine is least likely to appear from 12 to 18 months away from the completion, despite the process being fast-tracked. Other experts say this is too optimistic, and it will probably be at least 2 years until we have a safe and effective vaccine. While I was in Africa, I regularly took a drug to prevent malaria. It was hydroxychloroquine, or Plaquenil. This drug is now showing promise as an effective treatment for COVID-19. This is not a new drug. It was developed in 1955. There was a small but promising study in France recently in which it was given to 42 patients with the virus, and 100% of the patients fully recovered. There are several ongoing studies to verify that this drug could be the treatment of choice. This drug, which was approved for the treatment of malaria, is used in what we call, quote, out of indication. It means that it was never evaluated for COVID-19, since it was until recently COVID was not even on our radar screen. It's not against the regulations to use a drug which was approved for one disease to be used for another. There are many drugs, especially in cancer treatment, that are used for what we call off-label. There are many drugs that are being evaluated for their use in COVID-19. There is a difference in medical treatment between the words may and does. This drug so far may be a valuable treatment, but we cannot currently say it does. So one slide away from potentially bleak predictions, I wanted to fortify your confidence in sharing with you the ongoing and promising pursuit of potential game-changing vaccines, tests, and drugs. In addition, you should always remember the hundreds of thousands and perhaps millions who have been fully recovered from this virus. Here are some fine clinical points for the DSP to consider. Are people with epilepsy at higher risk of developing COVID-19? The available data suggests that just having epilepsy alone does not increase the risk of getting COVID-19 and does not increase the severity of COVID-19. There is no evidence that people with epilepsy alone have a weakened immune system. They should not be considered immunocompromised and would not have an immune deficiency from having seizures. Another clinical pearl and insight asks the question, do individuals with cerebral palsy have an increased risk from coronavirus? Having cerebral palsy does not necessarily put someone at higher risk of getting infected with coronavirus. However, if you have an associated condition of treatment that affects your immune or respiratory system, it may affect your ability to deal with the virus if you were to get it, and therefore puts you with cerebral palsy at increased risk. For example, some people with cerebral palsy have specific respiratory conditions such as asthma or have severe postural difficulties that affect their ability to cough well. While most of us are now familiar with the classic symptoms of COVID, fever, difficulty breathing, and cough, we now know that there are other asymptomatic, atypical symptoms that have recently been revealed. They include gastrointestinal disturbances, specifically loose stools and diarrhea, as well as loss of taste and smell. So the DSP should be aware of these symptoms as possibly being associated with the virus. So don't fall into being complacent if someone has diarrhea, and certainly do not totally discount COVID. Here are some take-home pearls. There's never been a situation that's been improved with panic. Misinformation is missed opportunities. Opportunities to better understand the natural history of the disease and the rationale for strategies designed for lowering its spread. Understanding why we do what needs to be done increases our compliance and adherence and leads to better outcomes. Use fact-based resources like the CDC and your state health departments. Provide active support during times of confinement. Isolation in individuals with low coping skills could lead to aberrant behavior. Be aware of changes in appetite, sleep patterns, behavior, confusion, bowel habits, personal hygiene, and the rejection of previous pleasure-seeking activities. Provide compassionate counseling and support. Refer them to the medical team if necessary. And certainly, and as important as anything we have previously discussed, take measures to ensure your own health as well as that of your family. Amidst all of these challenges, concerns, and questions, I'm afraid society's continuing devaluation of people with intellectual disabilities has once again reared its ugly head. Just a few days ago, several national disability rights advocacy organizations filed a complaint with the United States Department of Health and Human Services Office of Civil Rights about their grave concerns that the plans being put in place relating to the coronavirus pandemic discriminate against people with disabilities in violation of federal disability rights laws, including the Americans with Disabilities Act. The complaint focuses specifically on the plan released Friday, March 20th by the Washington State Department of Health in the issuance of guidelines relating to the shortage of ventilators and potentially other acute care services or equipment, and the criteria to deny care to people with disabilities with cognitive impairment. Just when we thought the inclusion of people with disabilities was part of the fabric of society, it appears that the disability rights movement is once again being summoned to fight another battle. We are strengthened with the knowledge that DSPs will once again be alongside us. Let me conclude with one overriding thought. DSPs have always been and will continue to be totally essential. Know that you are greatly appreciated by every member of the healthcare provider industry. Thank you and good health to you all.
Thank you, Dr. Rader. And if you could advance one more slide, please. This is Joe Macbeth again. Thank you so much, and I'd like to also thank your colleagues at the American Academy for Developmental Medicine and Dentistry. This is really important and practical information for direct support professionals, but I also ask direct support professionals to share this information with families, and also maybe review this information with the people that you support. A lot of really good, sound, practical information was just given. You know, after listening to the doctor, after all of this passes, and this crisis will pass, make no mistake, this crisis will pass. I hope that these valiant efforts and the professionalism that is exhibited by direct support professionals all over this country is finally going to be recognized, and recognized by policymakers and elected officials, so we can begin to have serious policy discussions about the value of the direct support workforce, about earning a living wage, and about creating viable careers. So when we reach a crisis like this and we enter a recession where we find millions of Americans out of work, that's the only time they come to these jobs. That is unacceptable. And we're reaching new audiences with these webinars and throughout all of the work that we're submitting to North America about the direct support practice. I want you to consider joining our membership. We offer a lot of information across many different types of training opportunities and access to newsletters and information that we share on a regular basis. Just please consider joining us. And join us April 3rd at 1 p.m. Eastern, 10 a.m. Pacific, when we have a live forum, a town hall forum with Dr. Rader, so we can start to talk with all of you. In the meantime, stay safe, stay healthy, keep the people that you support in good spirits, and we'll talk to you soon. Thanks so much.